Hi, hello friends. Today we are inviting Dr. Pedro. Sorry for the inconvenience. I got a call from the hospital.
Hello, sir.
Doctor, I'm extremely sorry. I got a call from a known patient. Had a history of
Okay,
fall.
no
His
problem.
daughter had a fall while playing. He told. I'm
Okay,
extremely sorry for that. Yeah,
let's go.
yeah. Let's start the talk. So, where do you work? In which place in Brazil?
I work in two places in Brazil. I work in a private and a public hospitals. The private hospital is a big hospital that is called Sírio Libanês. It's from the Lebanese people here in Brazil. So we have a huge hospital. It's called Sírio Libanês. And I work at the university that is called Santa Casa de São Paulo. Santa Casa is a
That's the capital city of Brazil.
no, the capital is Brasilia. It's a city in the center of Brazil that is called Brasilia. São Paulo is the largest city in Brazil. So we have
Acha.
20 million people. Yeah, yeah. It's the most important economical place in Brazil. It's São Paulo. But the Brazilian capital is Brasilia. It's a place that was built only to be the capital. It's a city in the center of Brazil. Yeah. And at Santa Casa, at Santa Casa de São Paulo, we have the university. It's a traditional university. The hospital is from the 1883. It is antique. And over there, we do our research and we publish our papers and we treat the public health over there. Okay.
Okay.
And I only
So,
do the knee surgery nowadays.
so you are into knee surgery.
Arthroplasties. Yeah. I work with knee surgery. And it's
Okay.
great to be here. I say hello to everybody. Thanks for inviting me, Sai.
Yeah. Yeah. So straight going into the topic. So what's your opinion about a partial ACL tear? So people come with a partial ACL tear.
Partial
Sir,
ACL. Yeah. It's a
should I
good
go undergo
question.
surgery or not?
It's a good question. And if we talk about partial, like one bundle lesion, yeah, I almost every time treat a partial lesion like a complete lesion, yeah, a complete tear. Why I say this? Because mostly if we have instability, yeah, if the knee is different from the other knee. But why I treat it like a complete lesion? Because even when we have a partial lesion, nobody can guarantee the intact portion of the ACL is good. Yeah, I don't know if the tissue is perfect. It's good because we don't have we don't know we don't have to the way to see if it's histological. See if histological is perfect. Yeah, so I treat the partial lesion like a complete lesion in
Complete
the
tear.
most of kind. Yeah, I don't know
If
what
the
you
patient,
think.
and if the patient doesn't have any symptoms,
Yeah, but if he
he has
doesn't have
only
any,
pain. He has only pain.
but if you have only pain, but I see that there is instability, I treat like a complete lesion. So they call me, but do you reconstruct the partial lesion, the AM or PL bundle only, or do I reconstruct the entire ligament? I prefer to reconstruct the entire ligament so I can be sure of my positioning. I can be sure that I'm making a whole ligament again. Yeah, it was clear.
So you do anatomical ACL double bundle technique or single bundle ACL
Uh,
reconstruction?
my dream is to do double bundle technique. Yeah. Why? Because I think the double bundle studies that from 15, 20 years ago started to show us the importance of the anatomical ligament reconstruction. Okay, the double bundle makes more damage to the bone tissue, so I think it's not so good. And if we have to review this ligament, if we have to make a new surgery, it would be difficult because of the bone lesion. So I do anatomical single bundle reconstruction, but I like the idea of the double bundle reconstruction. Yeah, so, but we do the anatomical reconstruction. I have a published kind of reconstruction that we call functional anatomical reconstruction. It's the way I used to do my reconstructions. It's published on England. We publish on England at 12/18, I think. But I do single bundle reconstruction.
What is functional single bundle? I did not understand.
Yeah.
See, usually what we do is, if he's an athlete, we do a bone BPTB. If he's a software engineer,
I almost only do nowadays the hamstrings tendon reconstruction. The functional anatomical reconstruction is a paper we published at England at 18. Yeah? It's a way we look for the intercondylar notch, and it's where we put our femoral positioning. Yeah, we call that a functional anatomical reconstruction because it's more for in direction of the AM bundle and in direction of the intercondylar bridge, the residence bridge. Okay, you can see it on the literature. It's on after I pass here, but we publish it at 18. It's a way we call our reconstruction. Okay, it's a single bundle reconstruction that we put in the functional best part of the ACL, and we use hamstrings for this. Last year, we published another paper that we compared the PTB with hamstrings in soccer players, and we saw that they are the same result. Okay, we have the same result.
oh, really? Oh, quite interesting.
Yeah, because here in Brazil, there's a fight that some surgeons says that for soccer players, it has to be the PTB, the patellar tendon. So we make 64 soccer players here. We operated 32 with patellar, 32 with hamstrings, and we show the same results. The patellar group showed a little bit pain when they kicked the ball. When they hit the ball, they had a little bit more pain. But the results, like in 2 years, showed the same. The results were the same. So we after we published this, we started to do more and more hamstrings. Okay.
Yeah, Sen, what's your opinion on conservative treatment of ACL tear?
My opinion is not so good on this. I
No,
don't
no,
like
you operate. See, you operate every ACL, or what's your idea about copers and non-copers? When do you tell, okay, you can?
I don't like this because the copers may have 5, 10 years with no pain, with no bad results, but with the time we can have a ramp lesion. With the time we can have a meniscal tear. So I don't like the idea of non-surgical treatment. I like do you operate all of the ACLs? Almost all, almost all. But the patient don't have pain. But if there is a Lachman positive instability difference between one knee and the other, I choose to operate.
So,
why this? Because if 5 years later, 6
he
years
will develop
later,
meniscal tears and all. Yeah, you are true. You are true. I agree with that.
yeah.
So
we lost the chance. We lost the chance. Okay.
Lost the chance. Yeah, you are right.
Yeah.
Yeah. What's your opinion about all inside ACL reconstruction? When do you do all inside?
I like all inside ACL reconstruction. I used to do a little bit, but today I'm doing lots of extra-articular reconstructions too. So, and I don't like the Lemaire technique. I don't like the tenodesis of the lateral tenodesis. I prefer the reconstructions of the lateral or medial structures. So nowadays I don't do a lot of all inside. I prefer outside in or in out, anatomical in out. So and I don't do lots of all inside, because to do my extra articular it's
Dr. Pedros, I am extremely sorry. I apologize you. A
no, it's
patient is
okay,
calling regarding the elbow injury. Huh?
no
Today is
problem.
a busy day in Hyderabad.
It's good. It's good to be
So,
busy. Let's go.
yeah.
We were talking about the
So,
all inside, yeah.
yeah, all inside. So,
Over there you do lots of all inside or no? What do you
yeah,
do?
we do all inside. See, all inside, basically, we need a flip cutter, na? So, it
Yeah,
is bit costlier.
yeah,
So, if the patient cost is not a factor, then we try to do all inside, because where we
okay,
preserve a lot of bone.
yeah, yeah,
So flip
true.
cutter, it costs some 20-30,000 extra. So I don't know exact money, but it's
No, no,
bit costly.
yeah, yeah, yeah. It's not cheap. Okay,
Exactly.
let's
So
go.
if the patient has insurance, it's not a problem.
Okay,
So that is
yeah.
how.
Here we
Yeah.
have this problem too. If the patient have a good insurance, we can do all inside. But as I talked you, we like to do extra-articular reconstruction. So we do more and more extra-articular reconstruction passing the time. So the all inside is not our preference.
No, why you do lot of LETs? What is the reason? To give extra stability?
Yeah, to have extra stability. And in the past, I believed that all the control was given by the ACL. Okay, the rotational control, the anterior posterior control, and nowadays I'm even more believe that the ACL is not responsible for all the control. So I see that the extra-articular ligaments are
Very important.
very important for the control. So when the time is passing, I do more extra-articular, and I believe that in the future I will make extra-articular for everybody, and not
So
the not
one
the
more thing I would like to
extravagant.
know.
Sorry,
Yeah. Yeah. What's your post-op protocol, post-op rehab protocol for soccer players?
for soccer players, the return to play is with 8 to 10 months. So the protocol is the same for everybody. They walk in the first day. When we have a meniscal tear, like the ramp or the root repair, we give them not to walk in the 2 first weeks with the cat with supports and
Non-weight
things
bearing
like
with
this.
crutches for 1 month.
Yeah. But if they don't have meniscal lesion, they walk in the first day and they will return to play with 8 to 10 months. Yeah, the 6 months. Yeah. When they return to play, when they return with 7 months, they have a new lesion, 50% less than when they return with 6 months. When they return with 8 months, they have 50% less lesion comparing with 7 months. When they return with 9 months, they have equal re-ruptures. So 8 to 9 months, I think it's okay. What
Yeah.
we like to do,
Even in India,
sorry?
we follow the same. Even here,
Sorry?
we follow the same.
The same, yeah. And what we like to measure is the cardiovascular. If, how can I say to you? If the cardiovascular is prepared too, because the muscles can be great, but if the cardiovascular is not great, they will be tired first, and the rupture risk are great. Yeah.
So when do you do a meniscal repair, and when do you do a meniscus partial meniscectomy? What's your criteria?
Perfect. This is a good question, and this I study a lot. Let's talk about meniscal lesions that can be repaired. Okay. The meniscal lesions that cannot be repaired, they will not be repaired. So when we have meniscal lesions that can be repaired, what lesion I repair? With ACL lesion, I repair all, medial or lateral, okay? Without ACL lesion, I repair lateral everybody, medial not everybody. I think medial, I can do a meniscectomy and with no, I do lots of meniscectomies, medial meniscectomies without ACL lesion, okay? Because I think they will not go well. The medial meniscectomy, in most of cases, go better than the lesions that you repair, and they not go so well. I don't know, what do you think? But I follow this criteria. Without ACL, I repair all lateral, not all medial. With ACL, I repair lateral medial.
See, if the meniscus is tear is a old tear which cannot be repaired, so obviously we cannot repair, right? It's a old chronic tear which doesn't have good tissue quality.
Yeah,
So I think that
yeah.
is the criteria. That's what I feel.
Yeah, but the criteria of lateral and medial, you not repair everybody. It's good. Yeah, I have some patients here. Like the last one is a soccer player. I made the ACL, I made the lateral root, and a single point, a single repair medial. That the medial seems to me the most the that how to say, the better lesion. Yeah, the medial seems to be the better lesion. The ACL was good, the lateral root repair was good, and the medial meniscus failed. So I had to reoperate and take off the medial. So the medial meniscus, we have to look with careful.
Why it
For
doesn't
the
heal properly, or what is your opinion? What is
no,
the
no, no, no. The lateral heals better than the medial. Okay.
Acha.
So lateral, even when the lesion is terrible on the lateral side, I'd like to lots of points, and lot of knots and try to give lateral a chance. The medial, when I have some doubt, I don't give a chance.
So again, coming to the meniscal repair techniques, yeah, we know that for the posterior horn, we usually do a all inside technique. For the anterior
Okay.
and anterior and the anterior horn and the body. So what techniques you follow?
I used to do lots of inside out, yeah, with a little cut in the medial or lateral side to do inside out techniques. I like
Inside out and outside in.
inside out with the
Inside
needles.
out will be a big scar, no? Will they accept?
Sorry?
Big scar.
Yeah, a little scar, like 3 centimeters, okay? But I like it because I feel the meniscus in my hand and I think it's very good. Nowadays, I do lots of out-in. In the past, I do out-in for the anterior horn, but nowadays I do lots and lots of out-in because of the smallest scar. I agree with you. But inside out, I think is very good. Okay, inside out has a problem that sometimes in this scar the patient have pain in the scar because of lots of points over there. But inside out, I think is very good. When we have a bucket handle, yeah, I like to do to position the meniscus, and I give in the center of the meniscus in the medial portion 1 point inside out, and then I have the meniscus in my hand to work in the anterior portion out in the medial portion. If I have the scar open, I do inside out. I like inside out.
So you use AC bond or which suture material you use?
What suture? For the posterior horn, I use the Smith Nephews all inside the fast fix. Yeah.
Yeah, fast fix. That I understood. For the all in, sorry, inside out and outside in, you use any AC bond or?
No, I use H-bond. Yeah, H-bond or the inside out. We have the Smith Nephews that have I don't know the name. The Smith Nephews 2 needles. Yeah, and there is I don't know what kind of suture is. And we use the Smith Nephews high ultra. I don't know the name of the. It's better
Ultra
than
bright
H-bond.
sutures.
Ultra bright. It's better than H-bond.
Okay, nice. So root repair, regarding root repairs, what technique you use? Do a double tunnel, single tunnel?
Yeah, I do single tunnel. I used to do double tunnel. Yeah, and then in the bone bridge you can make your knot. Okay, but nowadays I use single bundle, and we use 2 mini tapes. So I make my point with 2 mini tapes at the posterior horn, and then with a single bundle I pull these 2 mini tapes. There are 4 tapes. Yeah, making 4 tapes, and I don't use endo-bottom anymore. Now I use a knotless system. How do I say to you? It is called footprint.
Suture bridge. Sorry, what do you call the endo?
Yeah, it's called footprint. It's like a biotenodesis screw, but
Acha.
we put the mini
Suture
tape with
disc.
this.
Use suture
Sorry?
disc. Suture disc.
No suture disc. It's footprint. It's an anchor. Yeah, it's an anchor that we put the mini tape inside it, and we still looking in the arthroscopy, and we putting this anchor and look in the arthroscopy. So it do you understand? It's get
No, whether,
a
yeah,
real
you
good
see, you check
fixation.
whether you are fitting it properly or not. That's what you are telling.
Yeah, and it have a real good fixation with the suture disc or the endo-bottom. I think sometimes you press it, but when we look at the arthroscopy, it's not so good. So with this anchor, like it's called footprint, the anchor. It's for Smith Nephew. With this anchor, we can have a good fixation. So it might prefer to do single tunnel, mini tapes, and this anchor footprint in the tibia.
So, what's your opinion about ACL avulsion fractures? I think it's very
Yeah,
common in soccer players because the amount of velocity that is involved.
Avulsion fractures are more common in young people, yeah?
Young people.
Yeah, and young people. So my opinion is that not everybody needs to be operated, okay? So, yeah,
You use a
sometimes you can...
screw or staple. How do you fix?
Oh, no, I fix with not a
Two
screw.
tunnels.
No, two tunnels. Yeah, two tunnels, each inside, and I pass and pull the ACL and I fix in the tibia. There we can use
So you
the
take the
bone
suture
bridge.
through the substance of the ACL and drag
Yeah,
it, pull
yeah,
it
through
down.
the with two tunnels, lateral and medial tunnel.
So if someone asks you, sir, will that not hamper the function of the ACL because you are literally squeezing it or putting more pressure over the?
No, I don't. I
What's
don't.
your opinion?
No, I think my opinion it's not an issue for me. It's not a problem for me. Okay, I think
You did not see any failure cases? Any failures of the
I don't
emulsion
have
fixation?
I don't have lots of cases of this. I don't remember a failure case. Uh, no failure case comes in my mind on this. I don't know. I don't know. I like to put this and to use the bone block as a recuperation system. Yeah.
So what's your post-op rehab program for the ACL avulsion fractures?
No, I think the patient need to walk. Okay, so they walk in the first days, and my post-operative
Immediately, second day,
treatment
yeah.
it's like the same. Yeah, but you control with CT scans, and if there is a bone scar and it's good, they return to play even faster than the ACL rupture.
So when do you start knee ROM?
Sorry?
When do you start knee range of movements, knee movements, knee
Oh,
bending? When do you
no. I start in the first time passively. Yeah, passively in the first time. I put a cast, and the
in the first
patient...
post-operative day itself? I mean, in the second day itself.
A little bit of motion in the physiotherapy passively, okay, and the patient get the immobilized like 3 to 4 weeks. Yeah, but
Cast.
I am with a cast. Yeah, I like early movement.
Oh, that's great.
Yeah,
Coming to PCL
perfect.
avulsions, there is a difference of opinion. Like you need not treat every PCL, you can treat it conservatively. You need not operate. So, what's your opinion on about that? So, when do you do a PCL avulsion fixation?
Yeah, I do. When I do PCL, I do transtibial tunnel. Yeah, I don't do the outing with the bone. When I
You don't do open.
operate the PCL, no, I do transtibial. I like to do PCL surgery. I like a lot. I make it single tunnel, but I think I have to think about double tunnel because the literature goes to the double tunnel. But nowadays I do single tunnel in the femur. Okay, the grade 1 lesion, I do not operate. Yeah, the grade 2, I seems I will operate 2 and 3 in everybody when they are unique lesions. Yeah.
Medial and posterolateral portal.
Yeah. In the past, every case. How do I do it? In the past, I didn't do the portal, and I thought it was, no, I don't need portals. No, it's better with a posterior view. You have to put your PCL over there. Yeah, like
Yes,
2 centimeters,
exactly.
2 centimeters from the plateau. Okay, so it's difficult, yeah? But you have to put over there, or if you don't do it, you make a mistake. So the posterior portal helps me to clean the footprint. The very important for me is cleaning the footprint, because if you don't clean, you cannot see the how do I say
You cannot see that exact area. Without seeing, how can we do that?
No, and
You
you
need to
don't
see
see
that.
the
You have to place that jig there. You have to
the most
drill it very carefully.
the most important part for me is to see the needle, the
Tip.
Kirchner, when we make our starting tunnel, because then we can protect over exactly and make the tunnel. So if you don't clean very well, you don't have the coblation to clean very well.
Okay. Nice, nice, nice. So, you did not tell about when do you fix a PCL? I mean, how big the fragment should be? Half centimeter, or what is your criteria to fix?
Uh, the avulsion fractures,
All avulsions.
the PCL. I don't have
Yeah.
a size. Yeah, if we have an avulsion fracture that is dislocated, I think with a posterior medial scar, we can fixate with a one. How do you say?
No, all PCLs, all avulsions.
All avulsions.
No, what is your criteria to do surgery? What is your criteria
PCL.
to do fixation? PCL.
PCL grade 2 and grade 3, or
Acha.
associated with another lesions. Yes, not the avulsion. Is the association with another ligaments or the instability. Yeah. The grade 1 we can. I never operate. Okay, but the grade 2, that lesion we have a little bit of doubt. I usually operate. I like the knee stability. I think the knee is prepared to have his stability, and every instability in the knee, it can be dangerous to the future. So if have a grade 2 instability, I used to operate.
Nice, nice. Yeah, it's a great honor to talk with you, Doctor. So the patient is repeatedly calling me. I think I have to go to the hospital now. Uh,
No, okay.
can we talk about MCL and PLC in the later talk?
Yeah. The MCL, it's a good talk. I like the MCL. I study a lot of MCL. We
Yeah.
have published
See, the
a
problem
new
is,
ligament in the.
yeah, I need
Sorry.
to go to the hospital now. They are calling me repeatedly. I'm very sorry for that. So we'll do next week the PCL, sorry, the MCL and the PLC.
Okay, perfect. I think
Thank you.
it will be nice. Thank you. Bye bye, everybody.
Bye.